Okay. Picture the bone marrow aspiration. Anemias. We didn't talk enough about anemias.
That's the next chapter.
That's why we didn't do it. All right, let's look at the next chapter, which is 30. Anemia just means you don't have enough red cells, right? Again, you got all those blue key terms. The key terms are going to show up in your reading. In this case, yeah, you're going to need to know what those key terms mean because you're going to read them in reports on the floor. You're going to read them in, they're going to show up on your text, in your test. But they're not going to show up as give me the definition of this. They're going to say things like your patient has non-Hodgkin's lymphoma. You better know what that means. What does that look like? Okay. We're going to talk about cancer in general. All right. So we're going to talk about leukemias. Where is that cancer? It's in your white cells of your blood. We're going to talk about lymphomas. Where is that? It's in your lymph system, right? We're going to talk about cancer in general. The specific locations of those cancer will kind of come up as we study the system, okay? But mostly it's going to be a general discussion of cancer, all right? General. So let's start with anemia. Let's go back just a minute. We can treat cancer. We can treat cancer so much better than we could even 5 or 10 years ago. People live a long time with cancer these days if we catch it and treat it and keep it under control. And sometimes we even cure it. We used to say if someone survived 3 to 5 years, that was a big deal. We have people now that are 10, 15 years out. And we're still monitoring them. Our drugs have gotten better. Our detection and diagnostics have gotten better. We just can handle it better. We've learned a lot about it. Can we cure it? Not always. But what we can do is we can treat symptoms ever so much better than we used to be able to treat symptoms. Some of the symptoms are just annoying, okay? Like you lose your hair. That is not going to kill you, okay? Losing your hair is a side effect. It's not going to kill you, okay? Some things like the nausea, the vomiting, we have medications that can help to control that. Some of the things that we can't fix, specifically, one of those is neuropathy. We really can't fix the neuropathy. And almost always there is some degree of neuropathy after people have had chemo. What's neuropathy? Yes, nerve damage. And often it's hands and feet are the worst, of course, because they're the most peripheral. Okay, or the most, peripheral appendages. But that's one thing that we really can't do very well, and we can control pain really well. We can control nausea and vomiting. We can, the alopecia, we really can't control that. We can predict it, and usually your hair comes back once you stop the chemo. It'll come back. Might not look the same. Like it might have been straight and now it's curly, or vice versa.
Why is that?
I don't know, but it's crazy.
My aunt now has like
Color might be even
tights
different.
and curls.
Yeah.
Yeah.
So I don't know why that is, and it isn't just on your head. It's your whole body. I mean, we notice it people's hair because that's a huge part of them, but it's not just that. I mean, it's your hair all over your body. Okay? And it might just fall over really very fast, like in a matter of a couple days. And you might have no symptoms, and then that in a couple days you're completely have no hair. That's a chemo thing. Chemo has side effects because chemo is not smart. It kills all cells. It changes all the cells. It doesn't just target one area of your body. It might target one kind of cell, but those cells are hardly ever just in one thing. And they're not just the tumor. Okay, so, anemias. We have different kinds of anemias. And I'm looking for. Inside here. It talks about the anemias specifically. So it'll talk about iron deficiency anemia, which is the one that we most commonly think of. Not enough red cells, iron is attached to red cells, so therefore they are anemic, right? That's the kind of anemia we see, for example, in young women of menstruating age, okay? Chronic blood loss causing that. Or we might see it in a patient who's had an accident and lost a lot of blood. Blood loss. Iron deficiency anemia. But there are other causes for that. Perhaps your body is not absorbing that iron. It's producing it, but it's available, but it's not being absorbed. Why? And so when you read about iron deficiency anemia, what is causing the anemia? In general, your signs and symptoms of anemia: fatigue, exhaustion, weakness, pallor, bleeding, obviously, dizziness.
Isn't there well, this would be, I don't know if this is true or not, but my mom is anemic, and whenever she has like her episodes, she'll get a craving for chewing on ice.
Yes, yes, they do, and also their tongue changes. The color, it can be beefy red and slick, really slick. Don't ask me why, but that's how it shows up a lot of times. And they do chomp on ice a lot. Chomp, chomp, chomp all the time. You have a goal with these people who are chronically anemic. Your goal is to keep them healthy enough to function. They're ADLs. Keep them healthy enough to function. That's the goal. It might not be perfect, but our goal is to keep you healthy enough to function. What are we going to have to do that? Well, start with diet and rest. Cluster your cares. Don't be in there every 2 minutes making them do something. Cluster your cares so that you bother them, they can rest. Okay? Sometimes they don't even have enough energy to eat. Okay? So don't bother them. What's the most important? Get that nutrition in them. Is it more important that they, you got choices to make. What, do we do this or do we do this? Or can we combine the two somehow and use less energy to do it? Goal, that's your goal. Okay, so, and you may be doing transfusions on these people. It's easy to give somebody red blood cells. It's not easy sometimes to keep them, because how long does a red blood cell stay viable? How long does it work in your body, a red blood cell? How long does it live?
120 days.
120 days. Okay? So you give them a blood transfusion, and they'll come back, because they're not making red blood cells. So gradually those blood cells, and they're not all dying at once, okay? It's not like you give them, and then, because in the transfusion, they weren't all the same age, right? When I give you a red blood cell transfusion, all the cells in that bag, 300 mils, are not the same age as cells, right? They're not all going to die at the same time. So gradually they become more and more anemic, okay? Then you give them more blood, and then gradually they become more anemic. If they're not making red blood cells, you gotta keep giving them. Okay. I used to have this patient, she was a nun, and she would come in about every month for transfusion, sometimes more often, but she obviously had anemia, all right? Wasn't making red blood cells, she'd have to come in and get transfusions. And she'd usually get 2 units at a time. Take most of the afternoon to give her her 2 units, and then she'd be gone. She was a wonderful lady, wonderful lady. I loved getting that job of giving her her blood, because she'd tell wonderful stories, kind lady, and you know, she really wasn't that sick as long as she got her blood. Okay, but you could, she's kind of like the Energizer Bunny, you know? It just gradually the battery wore down, and she needed more blood. It just be perky as she could be. She'd come in pale as her sheet. Okay, so anemias. We can have hypochromic. Chromic, that means color, right? Chromic. Hypo, no color. Well, no energy either. So this is iron or vitamin deficiency anemia. Iron or vitamin deficiency anemia. That's what we're going to talk about. That's the first one it covers. Then it covers thalassemia, which thalassemia is very genetic. We see it most often in people of certain ethnic groups. Jewish people tend to have higher levels of thalassemia. Mediterranean populations tend to have higher levels of thalassemia. Anybody here ever done 23andMe, the genetic stuff?
Mine's getting tested right now.
Yeah, it's one of the things that we've been able to test for that for a while, because the tendencies are so predictable, okay? It's just a genetic thing. It's like sickle cell anemia shows up most often in certain populations. Well, African American people tend to have higher levels of sickle cell anemia. Doesn't mean they're the only population that gets it, but it tends to be much higher in that population. Okay? That's one of the things that 23andMe can pinpoint right out. Do you have any of that in your DNA? Even a small percentage increases your risk. Okay? So thalassemia has to do with not producing hemoglobin. Okay? You produce red cells, but you're not producing the hemoglobin that needs to be attached. And so then you don't have what you need to make the correct erythrocytes. And that's very genetic.
Mine's getting more towards the Mediterranean Sea, or the Equator.
I have no idea. No idea. It has to do with DNA, of course, you know, in that population, which is tight. But yeah, I don't know. There are many diseases that you can put into a population because of DNA. DNA is a recipe. The recipe is always the same. However, sometimes the recipe gets messed up. And then we see changes. Sometimes it turns out better, right? Like you can run faster and jump higher and have better oxygen carrying capacity than anyone who ever lived. You're a specimen because the recipe got messed up. Or it could be the other way and your life isn't even viable because the recipe got messed up. But it's a recipe. Freaks outside of the norm happen because of DNA changes. If you're really smart and that interests you, that is biomedicine right there in a nutshell. We're learning so much about DNA from these studies that we're collecting data that we've never collected before. And we can use it in very good ways. We could also use it in really bad ways if we weren't careful. But So thalassemia is another type. Then there's megablastic anemias. Megablastic anemias can happen because of vitamin B deficiencies. Cobalamin is the big one. There's a chart on page 612. Folic acid deficiencies, cobalamin deficiencies, and just DNA mess-ups. Folic acid deficiency is really, really, really hard to correct in your diet. It's hard to get enough folic acid in your diet to have enough folic acid. Folic acid is important in developing fetuses. Before the mother even knows she's pregnant, those neurotube defects have occurred sometimes because of folic acid deficiencies. That's why we stress prenatal care. And really, as a nurse, I tell people all the time, prenatal vitamins, the only thing different between regular vitamins and prenatal vitamins, guess what it is? Folic acid. Will it hurt you to take prenatal vitamins your entire life? No. Do it. Because folic acid is cheap, okay? And first of all, your health insurance might pay for prenatal vitamins, and so there you go. You don't have to buy them. You can buy folic acid at Walmart or Walgreens. You can just buy it and take it. It's cheap. It's a B vitamin. But without it, and you can't get enough of it in your diet very easily. For the test, know what the food sources are for that, because I'll be asking you that. Don't miss that question. Because it's really important that you teach people about folic acid. You'd have to eat like a bushel of spinach to get enough. Okay? I like spinach, but that's like not gonna happen. You know how, I just saw the funniest thing on YouTube, or on Facebook yesterday. You know that nasty, brownish, watery stuff that gets in the bottom of the bag of lettuce when it gets too old? Donuts don't do that. Yeah. Cobalamin is another one. These are all B vitamins that people become deficient in. If you're deficient in B vitamins, what does it look like in your patient or in you when you're deficient in B vitamins? Neurosymptoms, numbness and tingling. What else? Before even numbness and tingling. Confusion, lethargy, no energy. Heck yeah, you want to rush? Take a B complex every morning. It's better than coffee because it works. And water-soluble vitamins as opposed to fat-soluble vitamins. You can't overdose on B vitamins. Okay, it's probably why the United States has the healthiest sewer system in the world. Because we all take supplements and we pee them right out and flush them. Okay? However, it's not all bad. Don't be deficient in something that's just not necessarily, you can get all those in your diet, but the folic acid's hard to get enough of in your diet. You have to be really cognizant of that to get enough. Nuts. Fat-soluble vitamins, you can overdose on those because they're stored in the fat. And there are actually symptoms for overdosing. One of the most common ones is probably A. What are the fat-soluble vitamins?
A, B, and K.
A, B, E, and K.
Or all they eat Krispy Kremes, yeah.
Good one. So,
Taught us that one yesterday.
the other thing you're going to have to remember, because it'll be on your NCLEX, and I know I'll ask it to you some point, maybe more than once. Calcium. Remember fluid and electrolytes, we talked about calcium? Your body cannot use calcium without what?
Vitamin D.
Vitamin D. At the same time, not later in the day. Gotta have it. Okay. Folic acid deficiency, read that, know that table on 30-8, because it'll help you. Because it talks about megaplastic anemias. Cobalamin, folic acid, those are your main ones. Occasionally, we have people who are born without specific things that allow them to metabolize those. And it's usually folate deficiency, and it's usually the inability to transport those B vitamins within their body. But it's the same thing. It's just the fact that they're low on those B vitamins. What else do I want to talk about? Perhaps aplastic, malfunctioning bone marrow. Aplastic, whenever you see aplastic, it's malfunctioning, and we usually associate that word aplastic with what disease? Cancer. Yeah. Aplastic cancer. Genetic factors, we talked a little bit about that. Sickle cell anemia, we do need to know about sickle cell, and the book talks about that. On page 616, sickle cell is an inherited thing, therefore it's a genetic disease. We see it most commonly in African American populations, but we don't exclusively see it there. The shape of the cells is actually altered. They look like little discs that are kind of scooped out. And so because they're misshapen, they are unable to transport the iron and the hemoglobin and the things that the red cells need to transport for the body. They also then interfere with perfusion, oxygen perfusion, because the oxygen can't attach properly, right? The oxygen molecules. So we see cells starving for oxygen. That's painful and dangerous and deadly. And so these people will do pretty good for a while, and then they'll have an exacerbation. And when they have an exacerbation, it's incredibly painful, and it's very serious, okay? So they show up in the emergency room. Maybe we do some things to, how do we treat them? How do we diagnose them? How do we, but we almost always have to transfuse them because they need normal shaped cells, and they don't make normal shaped cells. They make sickle shaped cells. Ooh. Okay, so it's permanent. Okay, but we learn to they have to learn to manage it the best they can, and really they can't control it. It just happens at certain points. Okay, so it's not like they do something that makes it worse. It's a genetic problem. Right? It's very painful. It's very serious. Because it causes vaso-occlusion to areas of their body. The sickle-shaped cells, they like don't pass well into small capillaries and small vessels, and so they'll clot up there, and then you've got no perfusion past that point. Okay. So make sure you read that sickle cell. Kind of got out of my way, but I was going around the circle here. Of course, bleeding, yeah, if you have bleeding, you're going to become anemic because you lost too much. We can fix that usually, unless it happens because of a disease. Okay, so like you have a leukemia, or you have a cancer, in your body makes, epogen, its own, epogen, okay? It makes its own supply. However, if your kidney, it's made in the kidneys, all right? It's in the kidneys. If your kidneys aren't functioning, you may not be making it. You have to have erythropoietin to make red blood cells. The erythropoietin is made in the kidneys. It's used in to make red blood cells, but if your kidneys aren't functioning and you're not producing erythropoietin, you can't make red blood cells. That's a secondary, and that's what he's talking about there with chronic kidney disease. Your book also talks about that, and it's going to talk about that in, where am I? Talking about erythropoietin.
It's actually in chapter 30.
Which one?
Chapter
30.
under blood cells.
Which page?
Well, mine's different from yours. It's 615 in my book.
And
It's
under which
620.
head? Under which heading?
Blood.
It's 626 in the newer book.
626?
Yes.
That seems the right part. And it talks about erythropoietin.
Oh, I thought you were talking about hemophilia.
Oh, hemophilia. Yeah, I'll talk about it there. There are questions about hemophilia. Hemophilia is also an inherited disease. Hemophilia is an X-linked disease, so females are the carriers. It's carried on the X chromosome, but it most often shows up in males, because they only get one X. So if they get the X that's the carrier X, then it's gonna show up there. In females, it can show up, but usually they're a carrier. So if you are talking about hemophilia, well, we'll get to that. I want to finish this one. Intrinsic factor. What is intrinsic factor? Somebody tell me. Anybody remember what intrinsic factor is? What it does? Well, you need it to make blood cells. You need it. And there is a disease, there are some diseases which you don't produce it. So once again, if you're not producing it, and you may have produced it all your life, and then all of a sudden you're not producing it. So we see pernicious anemia sometimes in elderly people. Usually these people show up young, and they take vitamin B shots all their life to offset the pernicious anemia. I once took care of an elderly lady in the nursing home who had been giving herself vitamin B shots every week since she was like 12 years old. She was in her 90s because she had pernicious anemia. Her body didn't produce intrinsic factor, so we have to keep replacing it. Okay, so read about the different kinds of anemia. Don't get yourself bogged down by all the cellular level stuff. How does anemia look in your patient? Okay? How does it look in your patient?
The erythropoietin is on page 589. It's in chapter 29. different than yours, sorry.
$5.89?
Yes, $5.89, and the new one.
Gotta find it. Erythropoiesis, it starts on the bottom of 588, and it goes, and they talk about erythropoiesis. However, erythropoietin is actually produced in your kidney. Normal people produce it in their kidney. And it is required for the making the red blood cells. If you've got kidney problems and you're not producing erythropoietin, we can give you erythropoietin. It's a shot. We can give it every so often and keep that stimulated. But we gotta first figure out that that's why you're anemic all the time, and that you're not producing it, okay? And commonly, if you are a kidney failure patient, you'll be getting that medication. There's one that's produced in your gut. Can't remember what it is right now, but maybe it'll come back to me. Oh, here it is. This one talks about the causes of your anemia, okay? So, in a nutshell, you could be anemic because you have decreased production of red blood cells, okay? Either because you're not producing erythropoietin, or you're deficient in some of the components that you need to produce those cells that are found in your gut, like the iron and the cobalamin, which cobalamin is in your gut, that's the one. B12, folic acid, those all come through your gut. Or it could be because your liver is not storing it properly, okay? So you have a decreased production. You could be having it because of blood loss, all right? Either trauma or bleed somewhere, blood loss. Or you can have anemia caused by too fast of destruction of those cells, those red cells. They're dying prematurely. You're making them, you're not bleeding out, but they're dying too soon. They're destroying themselves too quickly. And that's the sickle cell disease medications, drugs, maybe chemo, whatever it might be that's killing it off. Incompatible blood. Oh, that causes bad problems with destruction of cells. Like, it'll kill itself off. Okay, you get an incompatible transfusion. Or the other one, the reason they're listing trauma here is because if you have a big trauma and we're giving it, and you're bleeding, and we're giving it, and you're bleeding, and you're giving it, and you're bleeding pretty soon, you got those immature cells, and you have no clotting factors left. Okay? Which is just gonna cause more bleeding. Okay. You learned about Z-Track IM injections, right? Where you Z-Track them, pull the skin, go in, pull it out. Those are kind of controversial, but we teach that, Z-Tracks. Don't know if it really works, but we teach it. If your patient's getting oral iron, they can be given as a tablet, or it can be given as a liquid. It is very staining to the teeth, so we want to make sure we give it so that it's not coming in contact with the enamel of their teeth. So sometimes we give it to them with a straw if it's liquid, okay? So that it doesn't come in contact with the enamel. They usually need taught about that. We give it to babies. That liquid iron in their vitamins tastes absolutely terrible. Have you ever tasted it?
Yeah.
Oh my God, it's terrible. So like the most bitter metal taste you've ever had in your life. It's like liquid iron. And they don't have teeth, so it's not a problem. But as they get older, it could be, okay? And the food sources, talked about that. Thalassemia, we talked about that one. Mediterranean group. People who have hepatitis C are also at big risk for thalassemia. Skipping through these. Talked about sickle cell. I like these little cartoons because they help you to remember the symptoms and how it looks in your patient. So I try to give these to you as much as I can, okay? Hop to it. Remember that. It'll be helpful to you. Hop to it. Hydration, what would that do? What would that do for your patient? Dilute it, right? It's going to help the blood to be less sticky and thick, diluted. Oxygenation, why? They're not carrying and they're not perfusing well. And then P, pain relief. This is incredibly painful. We usually see it in joints or appendages. That's usually the first places that we see it. Wait. Some people have too much iron in their body, too much, and their blood gets too thick and too sticky. This is hemochromatosis, too much. Too much vitamin C, too much iron. We gotta slow down on the vitamin C and the iron supplements. We may actually have to do some removal of blood on a fairly regular basis because they have too much red blood cells. Too much red blood cells is not good. We want enough, but we don't want too much. Usually we see this in liver patients, but liver cancer patients, but we can also see it in general population. Most often affects Caucasians between the ages of 40 and 60, and we usually see it more often in women than men. They absorb it too much. Could be because they're so good at supplements. Polycythemia vera. Oh, these words are crazy, aren't they? Try to separate out the word and figure out what that word means, and you won't have to remember hardly anything because it'll all be part of the word that's involved. Poly, what's that mean?
Many.
A whole lot, multiple, many. Cythemia, what would that mean? Yeah, cells. We got too many red blood cells because our stem cells are making too much. They're producing too much. So the blood gets really thick and it clots really easily. Vera, that means very. Thrombocytopenia. Oh, this is a big word, but it's not a hard word. What are thrombocytes? They're platelets, right? Thrombocytes are the platelets. What do platelets do?
Clot.
They clot stuff. What's penia mean? A little tiny bit. So what it means, thrombocytopenia, just a little tiny bit of thrombocytes. So do you think you'd clot well? No. Because you don't have very many thrombocytes. You have penia thrombocytes. Whenever the thrombocytes fall below 150,000, we say it's thrombocytopenia. We have to have special precautions for these people who are suffering from thrombocytopenia. What kind of precautions are we going to take? How's it gonna look in your patient?
Bruising.
Bruising, purpura, petechiae. Are we gonna wanna give them a bunch of IM injections? Oh
No.
no, they'll bleed like a stuck pig forever. Or they might just randomly start bleeding from that site 2 days later.
So wouldn't we have to put like little bumper guards or like padding in there to make sure they don't bruise?
We
or
can
hurt
do
themselves?
stuff like that, but these people just might spontaneously bleed. And you have to think about what kind of a patient would be short of thrombocytes. What
Oh.
kind of a patient is gonna show up as short on thrombocytes?
Elderly.
Older person, cancer patient, they're killing off their cells, okay? Spleenectomies, or people who have no spleen, okay? We might have to take out their spleen. We might have to give them steroids to fix their, to compensate for the fact that we've had to take out their spleen. Bleeding, petechiae, headache, purpura. People who have bone marrow problems, for whatever reason, cancer is usually the main one, are gonna end up with thrombocytopenia. Whenever it falls below 150,000, they're at risk. Don't want them shaven with a straight edge razor. Don't want them walking around with no shoes on. Whenever we don't want to stick them unnecessarily, okay? I have had a patient with, their kidney failure, okay? So they had a dialysis port. Oh my God, that sucker would just randomly start to bleed like a pulse. And you'd have to put pressure on it. In the end, I'm sure that's why he died. Because he would bleed to death from that site if nobody was there. It just wouldn't quit. Okay? These people are really sick. Nosebleeds. Random, just all of a sudden nosebleeds. And it won't quit. There's a picture of petechiae and purpura. And it's just random, it just like shows up. Because the vessels are so weak, the cells are so weak. Then this talks about hemophilia. Let's see. You know the story of Tsar Nicholas from Russia, right? Y'all learned that in history? Oh my gosh. You weren't in my history class. Okay, so the kings and the royalty of Europe is all interrelated, okay? Because they would arrange marriages to strengthen their situations politically, all right? Well, they had one fatal flaw. They had hemophilia in the ranks. And so they would intermarry, and so the whole kit and caboodle was full of hemophilia. Okay? It's a very interesting study. Hemophilia. If you have a patient with hemophilia, what are you going to need to teach them? Like what? What if you got a 10-year-old little boy with hemophilia?
Teach him how to stop bleeding. Like if he gets a
Is he
bloody
going to
nose.
play football?
Be careful.
No contact sports. Yeah? No, if he falls down, these children can fall down and bleed to death. Just fall down, skin their knee, and bleed to death. There's a nasty picture of that in your book. I saw it. Page 627. This person just fell down. They'll just keep bleeding because they don't clot. There's no cure for this, okay? Because it's an inherited X-trait genetic disorder, okay? It even tells you that they're missing factor 8. How about their toothbrush? Need a good stiff bristled toothbrush?
No, soft one.
No, really soft. We need to make sure their nutrition is excellent, but that's not gonna prevent it. Nosebleeds, big one. Intracranial hemorrhages, could just be spontaneous from a little tiny bump. They bruise easily, their joints get swollen and painful because of the bleeding, and they're always at huge risk for GI bleeds. How does a GI bleed look or smell?
Bloating.
What? Bloating, black, tarry, sticky stools. Black, tarry, sticky stools. Is that old blood or new blood?
Old.
Old blood. But it's bleeding. What else? Tea-colored or cola-colored urine. That's blood in the urine. Urine should not be brown. If it's brown, it means there's blood in it. Coffee ground emesis. That's old blood. Coffee ground emesis is old blood. Bright red blood, that's active bleeding. That might be in your emesis. Bright red stool, that might be in your emesis. That might be in your patient. That's active bleeding. But that black, sticky, tarry stool, that's old bleeding. And the coffee ground emesis, that's old bleeding. And the tea or cola-colored, dark-colored urine, that's old blood. Of course, bright red blood in your urine means it's bleeding. But keep in mind that it's going to show up. Pay attention to it.
But not every case with bright red blood means that there's a GI.
Yeah,
Right.
big hemorrhoid.
No, it could be a hemorrhoid.
Irritation.
It could be several different things.
Same with black tarry stools, could be that they take iron.
Yes, iron makes your stools black and tarry. It also makes you constipated.
Yeah.
Teach them
that
that.
with new CNAs, they're like, oh my gosh, because they think black tarry stools, like they're bleeding, and I'm like, oh, they take iron.
Iron stools smell like iron.
Yeah, they does.
Black, tarry, bloody stools smell like you have never smelled before. They stink so bad. You can smell them from the hallway. You can smell them in Walmart. You can smell them from a mile away. Your nose is very valuable to you as a nurse. And it will be like, it will stick with you the rest of your life. You can walk down the street and smell people's diseases. You can smell death
Yeah.
because it's necrotic. It's a necrotic smell that you will never forget. And it comes from people's breath as they're dying. Death has a smell. And sometimes you smell it in an odd place and you'll be like, oh my God. And you just look around. I'm serious, you can smell that stuff at Walmart. You can see anything at Walmart. It's a study in people. And I talked a little bit about DIC. You'll learn a lot more about DIC when you take OB, and you'll talk about it again when you are an advanced med-surg. But it's dangerous, okay? People die from DIC. And here's a bone marrow aspiration with some DIC going around there. Please. Necrotic, that area right there is becoming necrotic. That's not good. Neutropenia. Okay, what are neutrophils? What are they? What do they do? Neutrophils. Which ones? White. They're part of the red, white blood cells. Okay, and it's penia.
So lack of.
Not enough of them, just a little bit. What could cause neutropenia? Well,
Chemo.
chemo, cancer patients, and too many NSAIDs. I'll tell you a nasty story about it. My boys are all wrestlers, okay? They've wrestled since they were probably kindergarten, okay? That's their big deal. They love wrestling. They're all out of school now, thank God. So we always go on this, wrestling season's coming, we gotta make weight, we gotta do this, we gotta do that, and then they start getting sore and they start getting injured, and I have this one that would just take ibuprofen. Never say a word, he just takes more ibuprofen. Pretty soon, every time he's wrestling, he's getting a flippin' nosebleed. And I'm like, what is wrong with you, Tucker? Nothing, I'm fine. I'm like, well, you're losing too much blood time, so you better figure it out, because you only get so much blood time, right? Well, he was just taking so many NSAIDs. Too many NSAIDs makes you bleed. Old people come in with GI bleeds because of NSAIDs. Right? And they don't know, because they don't know. You buy that stuff over the counter at Walmart and Walgreens, so it's got to be good, right? Nope. Too much is not good. Tylenol is probably the most abused drug in the entire world. Tylenol will trash your liver. It's not an if, it's a when. How much do you take? Oh, you know, how many Tylenols? I got a headache. Somebody got any Tylenol? Yep, I got some. How many you want? Oh, give me 3. I'm like, no, these are 500. Well, 2 ain't gonna be enough. I got a terrible headache. No, I will not give you 3. Well, if a little's good, a lot is better if it's over the counter, right? People don't think of over the counter medicine as medicine. And they mix it. They mix it with herbals. They mix it with the stuff their doctor prescribed. They mix it with foods they shouldn't be mixing it with. They mix it with other medicine. Or they'll take Tylenol and they'll take cold medicine and they'll take Midol all at the same time.
I have a question.
Because they didn't read the dang package, okay? Yes, ma'am.
I had a client, she took Tylenol Max. And she took Tylenol like it was candy constantly. Yeah. And only reason I knew this is because the doctor ordered it that way, that she gets like 3 or 4 times a day max dosage every day. Like there's not a day where it's a break. Like
how much
day.
was max dosage?
I don't even remember.
What's the max dosage of Tylenol you can take?
Well, they say 3,000.
They used to say 4,000 max. Now they've lowered that to 3,000 max. And in elderly people, I would never go above 3,000 because their metabolism is slower.
Well,
and they're burning it much more slowly than other people.
Well, she would get the max dose, and then we would have it as a PRN, and then she requests the PRN, so she was going over the max dose.
I would do it, but that's her doc.
I never gave it to her. I would always we need to go talk to the nurse for.
Yeah.
I don't feel comfortable giving it to you.
Tylenol will crash your liver. You know how we first figured out that Tylenol will trash your liver? Okay, Tylenol is not a really old drug, acetaminophen. Okay, it's not a very old drug. When I was in high school, which was like a long time ago, when I was in high school was like when people first started seeing bodybuilders with trashed livers. And they're like, oh, these people must be taking steroids like nonstop, blah, blah, blah. Well, they weren't. Or maybe they were, but now all of a sudden they were seeing all these symptoms much faster. Well, they were taking all this Tylenol for muscle soreness and all that, which Tylenol's not good for that anyway. But we had this, before that it was aspirin. And we know aspirin is an antiplatelet, or is an anticoagulant, antiplatelet. So they would take aspirin before that. Well, Tylenol is much better for pain than aspirin, okay? So then we got this new medicine, this new crazy good medicine, the acetaminophen, we'll just take that instead. Well, then pretty soon we added that with the steroids they were taking, if they were, and those are anabolic steroids, which trash your liver. And so we'd see these healthy, young individuals with trashed livers. And we figured out, oh, they're taking like 10,000 milligrams of Tylenol a day. But we didn't know at that point. We had no max dosage. it was over the counters, and we didn't regulate and talk about it, we didn't have the research we have now. So Tylenol will trash your liver if it's not taken properly, and you gotta educate people, because they think that if you can buy medicine at, if you can buy stuff at Walmart or Walgreens, it's not really medicine, right? They don't think of that. Same way with herbals. They don't think of them as real medicine. They're just herbals. Well, no, you can't mix those with medications. Some of those are really bad to mix with medications. If your patient comes in for surgery and they're on certain herbals, you can't do surgery because they'll bleed. So you need to know what they're taking, and you have to specifically ask them about over-the-counter medications, and you specifically have to ask them about vitamins and supplements, because they won't consider them medication. Okay? And you know that those go in your body, they're doing stuff. Every medication has side effects. Every one. It's just a matter of if they're harmful or annoying or tolerable, or if we're willing to endure the side effect for the benefit that's involved. Okay? But every medication has side effects. And if you take more than about, I think the research said 7, I think it's 7 medications, you have interactions going on, period. Well, we doctors shop like no other, right? So we self-medicate at Walmart and Walgreens, and then we go to the eye doctor, and he prescribes some kind of drops. We don't know what they are, but we take them. And then we go to the doctor for something, and he puts us on something. And then we have this specific problem, so we go to another doctor, and he puts us on something. And then we go to the chiropractor, and he's telling us we should be taking all these supplements and vitamins, and pretty soon you got a whole big shopping cart. My mother is a hypochondriac, okay? I rarely take a pill because my whole life I've lived with this thing, okay? And she's not a dumb woman, okay? She's just hyper, like, I can take this for that, and I can take this for this, and blah, blah, blah. Well, now she lives in assisted living, okay? True story. About 2 semesters ago, I'm telling this story about polypharmacy, which Heidi's going to tell you this many times, okay? Because it goes on all the time. Well, my mother, who's really healthy, and I don't have a clue why she decided to live in assisted living, but I think she was just lonely, okay? I'm like, you should get a cat. But, okay, she lives in assisted living. And she loves attention. Okay, that's good. I just think she's lonely, but here she is in assisted living, and they give her pills. She goes to the doctor. He's very accommodating. They don't like to tell people no, and little old ladies have lots of complaints, and they give people medicine for them. She also goes to the chiropractor. He was giving her like 8 or 9 different things, supplements, which were not on the list, because she's taking those on her own because she's in assisted living, so she can take her own medicine if she wants to. Plus, she reads a lot on the internet, so she needs to take this and this and this and this and this. So pretty soon, she's like, I'm so weak, I can't even walk to the dining room anymore, and I have terrible diarrhea, and I'm just losing, I don't know what's wrong with me, I'm just getting old, and her memory's shot, okay? So she can't remember anything, she's very selective what she remembers. So, I'm like, no. You're having all this diarrhea, what is she losing?
Water,
What else?
electrolytes,
Electrolytes. Which messes with what?
memory,
Could be memory. Which one is that? The sodium. What else? Potassium, which messes with cardiac. What else?
magnesium,
Magnesium, which messes with and calcium, which is messing with muscles. Okay, so she's got diarrhea, okay? And I'm like, well, maybe you got a bug. her doctor puts her on an antibiotic. No, no, that doesn't get better. She just keeps getting weaker and weaker. And one of my students, we were having this discussion, one of my students said, I'm your mom's med aide. You should go look at her med list. And so I said, don't even say anymore, because that would be HIPAA, okay? So I went and looked at her med list. I went and looked in her room, in her cupboard. I filled a Walmart sack full of pill bottles, full. And that was without the list that she had in the med station, in the nurse's station. Her chiropractor had prescribed for her a whole bunch of probiotics. Do you know what those do? They make you poop. She was pooping her brains out. She was taking like 10 times the amount of probiotics she should have been taking. Plus she was taking stuff from her doctor, polypharmacy, demania, messed up your fluid and electrolytes, okay? She's already got a couple of things wrong with her that are like, she has some hemochromatosis, so she has to be careful. Too much supplements make it worse, which is why I think they diagnosed her with that. She was taking supplements they didn't realize she was taking. And I'm looking there and I'm finding, I said, Mom, why are you taking metoprolol? Your blood pressure has never been high in your life. Why are you taking that? She goes, well, my doctor prescribed it. I'm like, when? Well, come to find out, when they admitted my dad to the nursing home, my mother, who had been taking care of him for 20 years, and I mean hand over fist taking care of him, because that's the generation where he holds up his coffee cup and she runs and fills it. I mean, he doesn't even say, could you please? He just holds it up and she runs and fills it. That kind of caregiver. Plus my dad was chronically ill, and so she did everything for him. She did it for years, okay? She puts him in the nursing home and suddenly she has nothing to do. Nothing to focus on but her own little health. And she starts focusing on it, okay? Has an anxiety attack, thinks she's having a heart attack and goes to the emergency room, where an emergency room doctor finds her blood pressure is elevated and gives her metoprolol. That was like 2 years before this. She's been taking this metoprolol all this time, and she's never had high blood pressure. So if you don't have high blood pressure and you're taking metoprolol, that's going to lower your blood pressure. What does that do to you? What does that look like?
Fatigue,
Weakness, fatigue,
confusion.
confusion, could be dehydrated. Do you see how all this stuff fits together in your patient? That's your job. How are you going to rescue them? Well, I took her whole dang sack away. Okay? I chewed her butt like she was 2 because she knew better. And I went and talked to the nurse's station. Oh, and something else she was like taking way too much of. Calcium. No, vitamin C. Too much vitamin C, that gives you diarrhea. So she's taking all this probiotic, that gives you diarrhea. Too much vitamin C, that gives you diarrhea. She's taking blood pressure medicine she doesn't need, that's gonna lower your blood pressure. No wonder. She's probably lucky she was vertical. Okay? You gotta pay attention to this. I love working in the nursing home because you see that all the time. See it all the time. They lose a spouse or they have a life change. They're lonely. They're confused. They want attention. They need attention. Okay? So they start compensating. And you know what? Doctors pay attention to you. Only for a little while you're in the office, but they do. So you make a lot of appointments. Especially if you can afford it. Okay, so you got to use these kind of clues to help sort out what's going on. And you can't always get to the truth of that because you've got to get to the bottom of You gotta, if I had a student that said, you gotta go look at this med list. And it's, thank God the student paid attention. And we were having this discussion and she's like, oh. Yeah. So, neutropenia, how did I get there? Incense, too many incense.
Take a little break.
Yeah. Yep, you can.